Magandang araw po sa inyong lahat. Today we will be talking about major risk factors for cardiovascular disease. Let's start with hypertension. It is a fact that hypertension has an independent and continuous relationship with events such as intracranial bleeds, ischemic stroke, heart attacks, heart failure, and sudden death, as well as peripheral arterial disease and end-stage renal disease. It is therefore critical to improve the identification and management of hypertension, especially among high-risk patients, so that we can bring down related death and disability occurrences. As you can see from this graph, systolic blood pressure above 160 millimeters mercury alone can double or quadruple your chances for a stroke and heart attack based on a review of 420,000 patients followed for a period of 10 years. In 2004, the results from the InterHeart study showed that six major factors increase the risk for cardiovascular death and morbidity. These are smoking, diabetes, hypertension, abdominal obesity, psychosocial stress, and apolipoproteins A1 and B. What is worse, however, is that if you have a clustering of these conditions, say smoking, diabetes, and high blood pressure, the risk for developing a heart attack increases exponentially to as much as 16 times or up to 256 times that of a person without these identified risk factors. So it is absolutely necessary to detect the presence of hypertension as early as possible to treat it appropriately. Unfortunately, hypertension or high blood pressure is quite common. In 2023, the WHO said that an estimated 1.28 billion adults aged 30 to 79 years old worldwide had hypertension, and most or two-thirds of these patients come from low to middle income countries. Hypertension is quite prevalent. Based on 2019 WHO data, among Filipino adults aged 30 to 79 years old, there were 14.5 million who had hypertension. Of these, only half had been diagnosed, only 36% were actually treated, but only 17% were actually controlled. Even worse, hypertension was identified as the cause for cardiovascular disease deaths in 53% of these cases, or about 135,000 deaths. This trend continues because in 2022, hypertension was listed as the number 6 killer of Filipinos, causing the death of approximately 39,000 people in that year, and is thus recognized as a major public health problem in the country. Several international guidelines have been released over the last few decades, and these have been the basis for the diagnosis and management of high blood pressure all over the world. As you can see, the European Society of Hypertension differs from the American Cardiology Associations when it comes to cutoff values for hypertension and when to start the treatment. But even more important is for us to know what the Philippine guidelines say, because these recommendations will be the ones followed by PhilHealth and the other government agencies under the provisions of the Universal Health Care Act. So let's go over the 2020 clinical practice guidelines in the management of hypertension in the Philippines. Hypertension is defined as blood pressure readings of 140 over 90 or higher. And this is the level at which benefits of pharmacologic treatment supported by lifestyle interventions far outweigh the risks and costs of treatment. This aligns with the cutoff levels recommended by the European Society of Hypertension. The guidelines also stated that the preferred unit for blood pressure measurement is the automated oscillometric sphygmomanometer, or what we commonly refer to as the digital units. However, in situations wherein these digital devices may get confused, such as when there are frequent cardiac irregularities or very high or very low blood pressure levels, it is best to use a well-maintained aneroid sphygmomanometer, presuming that the operator is properly trained in this method. As previously mentioned, treatment is recommended for blood pressure of 140 over 90, and the target level to achieve control is less than 130 over 80 using clinic values. However, for patients who are 80 years or older, The doctor may opt to start treatment at 150 over 90 and aim for a level of less than 140 over 90 as the clinical target. Hypertension management is never complete without lifestyle modification. These changes would include cutting down on salt intake, eating more fish, fruits, and veggies, more whole grains and fiber, while avoiding processed foods, added sweeteners, and preservatives. Increased activity levels and resistance exercises may help in the journey to achieve recommended body mass index. It goes without saying that smoking and vaping should be stopped. When hypertension is uncomplicated, meaning it is not associated with other major risk factors or clinical complications, then it is considered okay to start with any of the available types of antihypertension medications, namely angiotensin converting enzyme inhibitors, angiotensin receptor blockers, calcium channel blockers, or a thiazide or thiazide-like diuretic. It is also possible to start with a two-drug combination if the doctor feels it is appropriate, for as long as they do not combine an ACE inhibitor and an ARB. If the initial BP levels are greater than 150 over 100 millimeters mercury, or if the patient is elderly and has a blood pressure higher than 160 over 100 millimeters mercury, it is suggested that treatment be started with two agents, preferably a renin-angiotensin-aldosterone inhibitor, meaning either an ARB or an ACE inhibitor, plus a calcium channel blocker or a diuretic, because it is unlikely that any single agent would be sufficient to achieve the BP target. It is acknowledged that single pill combinations may have its advantages, such as having less tablets to drink and improving drug compliance. But if it is not available or not affordable, then taking two separate pills are perfectly fine. Beta blockers may be used as initial therapy in hypertension if the patient has coronary artery disease, acute coronary syndrome, or high sympathetic drive. Beta blockers are also first choice in pregnant hypertensives. Certain drugs of this class also have evidence of benefit in heart failure patients, and these are bisoprolol, carvedilol, metoprolol succinate, and nebivolol. But there is one last thing that needs to be said about hypertension management. The intention is not simply to lower the number or numerical value of the blood pressure reading. What is even more important is that with blood pressure lowering, there should be an associated benefit of being able to decrease the occurrence of stroke, heart attack, and sudden death, as shown by this study, which followed up 1 million adults. And they were able to show that by simply lowering blood pressure by 20 millimeters mercury, this resulted in a substantial drop in the risk of death due to a heart attack or a stroke by as much as 30 to 50%. Please note that the maximum benefit is derived when blood pressure control is started among the younger subgroups. So how does the local guideline compare to those from the other parts of the world? As you can see, the Philippine Clinical Practice Guideline is more aligned with the provisions of the European Society of Hypertension 2023. However, all of them advocate that treatment should aim to achieve BP values below 130 over 80 in the soonest possible time. And with that message, we close this segment on hypertension. Now let's talk about dyslipidemia. Fatty acids are the basic building blocks of all lipids in the body. Steroids, phospholipids, and fatty tissue are three of the most important lipid structures in the body. Phospholipids are critical to the formation of cell membranes, while triglycerides are the most basic form of fat, often made up of three fatty acid chains attached to a glycerol backbone. Triglycerides are storage forms of energy and also serve as insulation and protection for the different vital organs. Steroids, on the other hand, are important components for the formation of hormones and cholesterol. So what exactly is cholesterol? Well, cholesterol is a waxy, fat-like substance that is needed for the formation of cell membranes, vitamin D, cortisol, estrogen, testosterone, and many other items. The cholesterol in the body comes from two sources, from external sources through food ingestion and endogenous production by the liver. Now, what are lipoproteins? These are the means by which lipids and proteins travel in the bloodstream. The lipoproteins provide a hydrophilic outer covering for the hydrophobic lipids and triglycerides, allowing it to be carried by the primarily watery content of blood. There are several types of lipoproteins, and they differ depending on the content they carry. Chylomicrons carry the most amount of triglyceride because this is the carrier molecule that aids fat absorption in the gut, while HDL carries the least amount of cholesterol and triglyceride. In terms of size, chylomicrons are the biggest molecule because it is the main transport of triglycerides from the intestines to the liver, skeletal muscle, and adipose tissue. Low-density lipoprotein, or LDL, carries the most amount of cholesterol, and its role is to deliver cholesterol from the liver to the body tissues. High-density lipoprotein is the smallest molecule, and its main role is to collect cholesterol from the tissues and bring them back to the liver for metabolism and disposal. That is the basis for the designation of lipoproteins VLDL, IDL, and LDL as atherogenic lipoproteins because they deliver triglycerides and cholesterol to the tissue, while HDL is considered anti-atherogenic because it is the reverse cholesterol transport, meaning it cleans up the cholesterol and delivers it back to the liver for disposal. Now, dyslipidemia refers to abnormalities in the level of cholesterol or triglycerides or both. It can be a primary or familial problem, meaning that the gene for abnormally elevated lipids was inherited from one or both parents. But the more common form is the secondary type of dyslipidemia, which may be due to conditions such as obesity, diabetes, hypothyroidism, and even alcoholism. This graph from the Mr. Fit study demonstrates the direct relationship of serum cholesterol level with coronary heart disease death rate. This means that if the serum cholesterol level is high, then the probability of the person dying from heart disease in 10 years is also high. Now, this graph shows a similar direct and linear relationship that exists between coronary heart disease risk and LDL cholesterol. Since the data was taken from lipid-lowering trials, the data shows that the lower the LDL level achieved with treatment, the lower is the coronary heart disease risk. For every 1 milligram per deciliter LDL-C reduction, the risk for coronary heart disease event is reduced by 1%. By calculation, the risk of CHD events becomes 1, meaning it is not attributable to LDL-C once LDL levels of 40 milligrams per deciliter is reached. This is one of the reasons why the target LDL cholesterol level is pegged at below 50 milligrams per deciliter. Just like hypertension, allow me to acquaint you with the latest Philippine guidelines on the management of dyslipidemia in the Philippines. As far as lifestyle modification is concerned, smoking cessation is strongly recommended for everybody. Second level recommendation is also provided for a low-fat, low-cholesterol diet, e-cigarettes and vaping cessation, and adequate weekly exercise. Statin therapy is considered first-line therapy for all forms of dyslipidemia in primary prevention. If your LDL level is greater than or equal to 130 milligrams per deciliter and you have two other risk factors as indicated in the slide, then you should start taking a statin. If you have diabetes, then you should also start taking a statin. The treatment targets are adjusted depending on the risk factor profile. If you are diabetic, then you should aim for LDL goal of less than 100 milligrams per deciliter or 2.6 millimoles per liter. If you have diabetes and two other risk factors, then you should aim for LDL of less than 70 milligrams per deciliter or 1.8 millimoles per liter. If you are diabetic and are extremely high risk for recurrent cardiovascular events, then you should aim for LDL goal of less than 55 milligrams per deciliter or less than 1.4 millimoles per liter. If the patient has primary hypercholesterolemia, then statin therapy should be started. How do we diagnose familial hypercholesterolemia? You can go down this list of Dutch lipid network criteria for heterozygous familial hypercholesterolemia. And if you get a score of 3 or more, then there is a possibility of you having that condition. However, if you get more than 8 points, you are absolutely qualified as a patient with definite familial hypercholesterolemia. Patients with familial hypercholesterolemia should be started on statin therapy. This is the summary flow chart on the screening and treatment of dyslipidemia. The most important points are that if diabetes is present, then statin should be started. If you have LDL levels greater than or equal to 130 milligrams per deciliter, and you have one of the other conditions identified on the list, then you most definitely need to start taking statins. As far as secondary prevention is concerned, once an acute coronary syndrome has been diagnosed, then the maximal dose of the high-intensity statin should be started immediately and maintained. This table shows the doses of each of the statins which would qualify them to be labeled as high-intensity statin. The most important point to remember is that statins should be started and not discontinued, and the dose must be at maximally tolerated levels. This graph shows us where the statins act to lower LDL cholesterol. Statins block the production of cholesterol by the liver and also promotes the hepatic removal of cholesterol that is already circulating in the blood. Ezetimibe, on the other hand, blocks the absorption of dietary fat at the intestinal level, thus complementing the work of the statins. That is why ezetimibe is recommended to be added on to statin therapy if the target LDL level has not been achieved and maximally tolerated statin dose. The routine use of fibrates on top of statin therapy in patients with or without diabetes is not recommended. The guidelines only specify a specific scenario when fibrates may be used, and that is in men with controlled diabetes who have very low HDL and persistently high triglyceride levels above 200 milligrams per deciliter. And this would be for the indication of prevention of cardiovascular disease. As for omega fatty acids, they are not recommended to be added onto statins in patients with atherosclerotic cardiovascular disease. However, pure EPA may be given in individuals who have achieved goal LDL-C, but with persistently high triglyceride levels above 150 milligrams per deciliter. This is the summary table of LDL cholesterol targets in different patient groups. In the event the target LDL cholesterol levels have not been achieved despite maximal statin and ezetimibe doses, then the newer injectable medicines known as the PCSK9 inhibitors may be added. For patients with hypertriglyceridemia, statins are still the first drug of choice based on the European Society of Cardiology guideline. If the statin therapy has an inadequate impact on the triglyceride levels despite maximally tolerated doses, then it may be justified to start a pure EPA preparation at 4 grams per day on top of statin therapy. Now, before we leave the topic of dyslipidemia, I just want to address the horror stories about the side effects of statins which are often mentioned. These are the 4 major concerns. Number 1, yes, there is a low risk for developing statin-associated muscle symptoms, but the benefits of cardiovascular risk reduction far outweigh the risk. Number 2, yes, Statins have been associated with an increased risk of new onset diabetes mellitus, but again, the benefits of treatment far outweigh the risk. Number three, no. Statins are not associated with the development of dementia and cognitive dysfunction. And number four, no. Statins are not associated with an increased risk of intracerebral hemorrhage. I hope that you will be able to allay the fears of patients who resist starting statin therapy and help make them realize the substantial benefit for cardiovascular disease prevention that can be derived from taking the statins. And on that note, we close this chapter on dyslipidemia.